think kidney cancer treatment moving forward very quickly is going to be that every patient's going to get an IO-based combo frontline. Might be IO plus IO, might be IO plus TKI, or IO plus BEV. Sorting out those differences will await, obviously, comparative clinical data and other factors that determine which patient gets which drug. But I think very few patients are going to get, say, TKI monotherapy once all these are presumably approved and we have full data and things like that. Next steps would then be figuring out what to do with patients who are refractory to these combos, because you're using both mechanisms up front potentially. So figuring out, are combos active in sequence? Do you get combo 1, then combo 2, then combo 3? Can you get away with giving monotherapy and then adding in the second drug only if necessary? So there's a lot of different ways, in drug development in kidney cancer and every cancer. A lot of times there's just these big phase 3s where things are put together and yeah, they work, but then we go back and figure out actually how to use them. Timing, dosing, sequence, those questions aren't often asked in the initial drug development. They kind of come later. And so I think that's what the next few years are going to bring.
I think the most promising thing on the immediate horizon is the application of immune checkpoint blockade in the earlier stage 3 setting. These agents have shown effectiveness in melanoma when applied to stage 3 patients. We know that they're active in melanoma. We know that they're active as single agents in kidney cancer now. So the hope is that translates into kidney cancer, meaningful improvements in disease-free and, importantly, overall survival in those adjuvant settings. That would be truly exciting for our patients. So preventing stage 4 disease from developing, that'll lead patients to lead a much longer life, much more improved survival. So to me, that's the thing I'm looking forward to over the next 5 years is how do those adjuvant therapy trials with immune checkpoint blockade read out? Well, it's an exciting time for our patients with new options that are meaningfully prolonging their lives and in some cases leading to complete responses, but it's hard to keep track. I would try to put things in different buckets. Most of what you're seeing in 2019 is the combination of VEGF and PD-1 blockade. Two great tastes that taste reasonably well together. And they work, and they improve outcomes compared to sunitinib. I'm not sure there are major distinguishing characteristics between them. So eventually people are going to pick the one that they're most comfortable with and probably apply it. And, we won't be using all 5 in our patients, but they'll be preferred in many patients because they combine 2 approaches that many oncologists are comfortable with and have been using for over a decade in the case of VEGF and over the last 3 or so years with PD-1. So I think people will find those regimens easier to apply than maybe they think. Where in the case of PD-1 and CTLA-4, CTLA-4 has carried a somewhat intimidating sort of reputation because of the immune-related side effects. I think we're getting much more effective at managing those side effects. I think to me that's the important take-home point that in 10 years ago with ipilimumab, we didn't always intervene aggressively, quickly with side effects. We let things smolder, trying to see if they would improve. Now we're very quick to act with immunosuppressive regimens that are much more effective than they were 10 years ago. So if you can educate yourself and your team about how to recognize those side effects and how to manage them, we're doing much better than we were. And what's exciting about those IO combinations is the chance for the complete response, which might lead to remissions of disease. So I think in my mind, I think that's the goal that most patients have, the chance to be treated, for the treatment to work, for it to stop, for them to live off treatment for a while. So I do think it's worth for the average, oncologist, the average nurse practitioner or nurse in oncology to learn about these new treatments, because I think it's really rewarding for me to actually occasionally present a patient with that opportunity. It makes you feel good about what you're doing to actually see an outcome like that. So it's good for both patient and clinician. We need to produce more of those remissions for patients with advanced kidney cancer.
Excellent. I think the next questions are, how do we cure more patients? Can we get away with monotherapy in some patients? Can we go the other direction and give triplets, right? Are triplets going to be viable? Are they going to be more curative? So I think for the first time in kidney cancer, I guess a message I'd like to get across is that I've shifted my thinking from, gee, I want to control this patient's disease as long as possible, to I want to cure this patient's disease, certainly in the frontline setting. I'm not so much sure in the second or later line setting, but in the frontline setting, I want to give them the regimen that I think has the highest chance of cure. and then I'll worry about the rest after that. And that's a different way of looking at patients rather than a sequence of monotherapies, and we're trying to control and minimize toxicity, which is still important, of course. But for me, fundamentally, and I think the field has shifted a little bit towards a more curative paradigm.